We have a great case, an interesting one. I'm joined by our extraordinary surgeon, Dr. Zain Khalpey. Congratulations on your new LVAD program that you've worked so hard to get up and running here. We have Mark Reisman and Jim Hermiller. And Mark made a point. It's the first time we've all been in the lab together in the 20-some years we've been working on this.
It's a trifecta.
It's a trifecta. It takes three interventionalists to match the wits of a surgeon, I suppose. We have a great case, and I'm going to kind of skip some of the formalities of introducing the room. You saw them all this morning. We do have Vince on anesthesia. We have our Protego system, and we've done a lot of fluoroimages. Just flip over to the badge readings and tell me what the badges say. Can you flip over there, guys? There you go. We're not getting any radiation in this case. But the patient is getting, at the bottom, a ton of radiation, but that's to be expected.
That would be going to your face.
Yeah, so exactly. That's what I would be seeing in my head, neck, and face. Otherwise, we're getting no radiation because of this Protego system. It's community protection. It's not just protection for the primary operators, community protection. Okay, let's talk about the case. Is our colleague, Dr. Per Summer, on the panel?
There is. Come on up.
And while Per is coming up, while Dr. Summer's coming up, could we Per referred this and another patient to us. He did a great job helping us to vet cases for this meeting. Could you put the PowerPoint up? And Per, every time you want him to switch, just tell him to switch, okay?
Yeah, so hopefully this is a great educational case for all of us. This is a 86-year-old gentleman who received a 25 millimeter Lotus valve for severe aortic valve stenosis in 2019. He had a complex LED intervention just prior to his TAVR in 2019 and also had a pacemaker placed after. Other comorbidities include atrial fibrillation that he has been anticoagulated with since his TAVR. He did very well with his Lotus valve up till a couple of months ago when he presented with progressive shortness of breath and was re-referred to our structural team. And if you see the numbers here, he has developed severe aortic valve stenosis of his prosthetic valve with peak velocities of about 4.5 meters per second.
Paced rhythm, okay.
Yeah, here's his EKG. Coronary angiography, you see there's a lot of distal LED disease that is relatively new, but a small caliber vessel, proximal LED stent is patent, and he has a moderate left circumflex artery stenosis that looks unchanged from 2019 when it was IFR negative prior to his TAVR, and then some diffuse distal RCA disease.
Okay, next. And this tells the story.
So great news for him with the Lotus valve in place. Coronary heights are great. Far away from the valve plane, there's plenty of room in the sinuses, so very favorable anatomy for a valve-in-valve procedure. And then here you just see the dimensions of the prosthetic valve. I think inflow about 22 to 23 with a 25 millimeter valve. And that's pretty much consistent throughout the entire Lotus valve without much variation between 22 and 24. So pretty consistent.
Go next. These are the dimensions of the Lotus valve. It's got a height of 19. You see the diameter. Not going to spend too much time on this. It has the polyurethane skirt at the bottom. And it was good for PVL. Hermiller describes it as somewhat of a tank. You could take on LVOT, calcium, and bicuspid valves. Go next. Jim and Mark, let's just go. We can go off the slides now. So, guys, we're trying to decide. You can come back live to us. We're trying to decide what's the view.
Yeah.
And we're trying to decide the depth. Now, I think the depth is probably taken off the table by A, we have a pacemaker, and B, if we just match the bottom of the polyurethane skirt, the bottom of the cage, we're good.
Yeah, no, we've talked about a lot. Getting rid of the parallax has been a bit of a challenge because of the way the the valve is designed. We're sort of using the post to try to create that height that's equidistant.
Can you go back a picture? Let's see the fluoroscopic images. Now, this is what we believe is as close to parallax out and a three-cusp view. You guys agree with that?
Yeah.
Yes. Yeah. And I think we should emphasize that those posts on the Lotus are right across from the coronaries.
Bob, you want to talk about that? I did not do this Lotus. I know I've done a lot, but this one's not mine. Bob, you want to talk about what you're seeing on this?
Yeah, so the easiest way to look at it is probably with just regular transthoracic, rather transesophageal imaging with biplane. And what we can look at here is you can see where the actual posts are, and then you see the left main, and there's a post just about right in front of it. There's a post that's almost directly in front of the right coronary. So it's sort of an anti-commissural view, if you would.
Anti-commissural view. I like that.
Well, in surgical speak, that's at the nadirs.
Yeah, like the
At the naders, yes.
Yeah, so I have you in my right ear, and I got Joanne speaking the King's English in my left ear. So this is
I'll speak the Queen's.
okay. Very good. Anybody on the panel want to add anything on this? Because this was very challenging for us to figure out just what we wanted to do. We're going to use a core valve. We're going to use a 26 core valve on this. Any more help, additional information from the panel?
Hi, David. It's Jonathan Leipzig. Interesting
Hey,
case.
Jonathan.
I would just share that we have some new data from Stephanie Sellers from the bench looking at post-implant valve-in-valve. And you look at the CT, you can see there's quite a bit of halt and a fair bit of pannus. And so, not surprisingly, I think that the expansion of the transcatheter device is going to be challenging in this case, which is why, obviously, a supraannular valve, I think, would be particularly helpful.
Okay. Thank you, John. It's good to have you with us. Anybody else? All right, so we're going to take the valve up right now. We got a 26 Evolut FX Plus. Let's take it up. Let's have that.
While you're taking that up, Dave, just for the panel, we've been thinking a lot about getting this valve, the transcatheter valve, with commissural alignment. And we're going to just do it the usual way here, but any thoughts anybody has, because the posts of this Lotus, and you can see how we've got them arranged here on fluoroscopy, would anybody do anything differently than standard approach to do what we do when we implant an Evolut? Wire?
Well, yeah, Jim, you're already misaligned on your commissures.
That wire came back, guys.
Aligning up the Evolut is probably not going to make a lot of difference. You're just going to put your poster down and cover more of the.
I need a pigtail.
The only thing I was thinking is actually the big gaps in the frame for the coronary access. If we could align those up this one, I agree with you. We're not going to won't make any difference for the Lotus, but will it make any difference when we implant this Evolut to try and get it so that the large area to get through to the coronaries are aligned appropriately.
I need the straight wire again, please.
Well, there's no sense in trying to implant your Evolut high. You've already got a pacemaker, so just keep your leaflets low.
Just get in there. That's what we were talking
That's
about.
what we decided. Yeah. We're going to do it the regular way.
Yeah.
Pin that wire.
Cut it.
I'll make one shot with this. Give me the straight wire.
And what was the inner diameter of this valve?
22.6.
22.
Okay. So it'd be a 25 portico if you want to go to a portico to keep really low, 26 Evolut or 23 S3.
Okay, can I have a straight wire?
Wire coming out.
Okay, thanks. Give me an 035J. What we're going to do is we're going to give me an 035J. We have to use the AL1 to get across.
Was this a tough valve to cross?
What's that?
Was this particularly challenging to cross? I find the recrossing
It was.
TAVR valves is not easy.
Therefore, it was, and therefore the loss of the wire was not my favorite choice.
Well, what makes this different from other TAVR valves is that's a solid piece of nitinol from the top to the bottom. There's no holes anywhere when it comes down. and it will not
AL,
expand,
please.
no matter how hard you push on it.
Yeah.
Herms, it's Megan, and I was
Zain,
just
does
thinking
anybody
about
have
your
does anybody
comment
have
about
experience,
placement of the second valve. And it is actually important because this patient does have coronary disease, and I think part of our role as structural interventionalists is taking care of our other coronary partners, so that when the time comes, if the patient should need intervention or STEMI, that we have educated them on all of these
Lead with
different
the wire,
valve
please.
platforms, which guides might be easiest, such as, downsizing or going from the leg more than we would from other strategies. But I think it is part of our responsibility when we're putting, especially valves in, that we're talking with our teammates in our meetings about how to access those coronaries during emergencies, because we're going to see this more and more, that need will arise.
Yep, good point.
We
Is there any
concentrate on
experience
all our
with valve and
self-expanding
lotus?
Anybody have experience with valve and lotus?
Nope.
No.
I can't hear the echo anyway.
All right.
Are you guys able to hear us okay? Are they hearing us, David?
Can you guys hear us?
Yeah, we can.
Okay.
Steve, did you want to go and make a comment? Do you want to?
David, we have experience with valve and lotus, probably on the lotuses that you came to proctor us on.
Probably, so it's my fault.
No. So, a lot of times, you're lucky in this case because the coronaries are quite high, so that's good and you have enough room. The real trouble on these cases occurs when they fill up the whole annulus and the coronaries are low, which often happen in those cases. So those are struggles, not only to cross as you're having here, but then to get back into the coronaries. I think you have an old case, David, where you were able to go through the frame of a lotus. I've never seen that again, but that was quite.
That was a case where the coronaries the coronaries were low as a 6 millimeter height coronary, and so we went through the braid frame. And when going through the braid frame, we're ready to go with the TAVR valve here in a second. But when we went through the braid frame, we were able to engage the left main, and then we ended up putting, go ahead. Now leave that wire there, please. Advance the wire.
So what would you do to keep the frame open, David? That frame will collapse again.
No, it's amazing. Get that wire out there. I don't want to work for this again. What we did was we torpedoed a guide extension through there, and then we put we put 2 wires actually, and there was no left main basically. So we put 2 wires through there, and we V-stented it was a separate osseous. So we V-stented the AD and the circ and extended that back into the braid frame. Worked fine. She did great. Okay.
It sounds like a combined orthopedic cardiology procedure.
You know what it was? It was a Friday procedure. Friday night at 8 o'clock procedure. And she was acutely sick. She did great, though. Okay, coming up with the Lotus. I'm sorry, with the Evolut FX Plus.
David, you want to stop and tell people how you're lining up your commissures there?
Well, I could use some help with that actually, Michael. Yeah. What would you advise?
Well, you're coming up and you come over in 20-30 LAO. You get the hat marker on the outside. It stay on the outside like it is. If you're in a coplanar, and if you roll over to a overlap, it'll come to the front. And if you know that, then you're lined up.
Okay, I'm going to pull the pigtail back. All right. So what would you recommend right now? Get that wire out there, please. Mag up, please.
Yeah.
Not a bad place.
That's good.
Yeah, let it drift down.
Okay. I don't know if pacing is necessary or not, but we're going to pace. So let's start pacing at about 120, if that's okay with everyone.
That's a great idea.
Hold the wire.
Hold.
Yes.
Okay. There you go.
Okay.
Nice and slow.
Ready?
Yeah. Thank you. I think that's fine. Hey, would anybody pace any faster?
Nope.
Pressure's down. It looks
Yeah,
great.
we pace between 120 and 140, David. Most people tolerate that really well. It depends on how much movement there is.
I'm going to hit Cine just to see what else we do.
Okay, stop.
Just
We
before
go
it's
slow.
about the flowers. It's probably going to be okay, Dave, right? Or maybe a hair in. Because again, we don't have to worry about pacing.
Go ahead.
That's good.
Slow.
Maybe a hair in, a little forward pressure. Yep. I like it.
Slow.
Like that?
Yeah.
Just slow.
Perfect.
This is where Yock taught us. Just put your beats on and go to your own pace.
Slow.
But I would have told you to land it higher.
Yeah, I'm thinking about landing it higher, actually. Okay, bring your pacemaker down to sinus, or to paced anyway, her paced rhythm. I think we're a little deep, don't you?
Yes.
Yeah.
Okay, recover the pressure, please. Pacemaker down. Pacemaker down.
But David, in this particular case, you could almost go inflow to inflow, so you could land it much higher.
Yeah, it might help, David,
Okay.
if you roll over to an overlap and rather than an LAO.
Yeah, well, that's what we were trying to find the overlap view. Okay, tell you what, why don't we capture this real fast? Capture it, let's go. All right.
May pop up a little.
You might have to help me out a little bit with some questions.
Pressure.
I'm getting to that.
Okay. Is our pacemaker still running?
We've got asystole. Got
There we
Here
go.
it comes. Here it
There
comes.
it comes.
She's paced.
Yeah.
She's
She's got a pacemaker.
She wasn't ages. Yeah. She just didn't have pressure.
You're not pacing there, right?
Captured.
And maybe
Okay,
a wire.
let's bring it back out. Let's bring it
Well,
back
give her a
out.
break for a second.
Yeah.
Okay, let's bring this out of the.
Can I help you on this
Come on,
side?
Ben. Yeah, come on. Bring the
Just
tablet.
roll it. Just roll it a little. No, not release. Roll it. Just roll it out. You're not capsule yet. Okay. Now come
There we
on.
go. Come on out.
Walk it out.
Walk it out. Leave the wire in and walk it out.
Yeah. Just push one. Perfect. You're right. Perfect.
Okay, good. All right, good.
Let her recover. Good.
There we go.
All right. Things are going great.
David, my guess is you're going to end up ballooning this evolute valve after it's deployed because there's so much tissue there in order to get a full expansion. And being just a little bit deep will probably give you a little more room for it to expand as it's ballooned.
Would you balloon it before?
No, not
not
I think we
before.
put it.
I think the nice thing was it was completely stable. So when you just do what we just did, we just have to be a little bit more aortic. And I think it'd be great.
All right.
And for everybody watching, that was actually an excellent move just to pull the valve back, let the patient breathe, and let the operators breathe as well. So, good move.
Okay, things are going great. We're going to let her recover. Just a little more shallow.
All right, let's recross here. Okay, let's not let that wire come back. Very good. Wire in.
Thank you.
Wire in. There you go. Thank you.
Wires.
Wire back a little bit. You know,
There you go. There you go.
Now.
there's a technique when that happens, if it, where you can snare it, but I didn't think that was,
No.
we were anywhere near having to do that. So we're going to come up. Wait 1 second.
Yeah, just remember, David, as long as you're in this coplanar, you're deeper than you think on the non-side.
Right. So let's start pacing again at 120.
Okay.
You say when?
Okay. Tell you what, Mark, I'll be the left brain, you be the right brain on this, okay?
Okay, so let's start rolling it out now.
Okay.
Slowly, nice and easy, good. Keep coming. I'll go a little deeper, Dave. And just give Cine, just so I can see the dots a little bit.
Yeah.
Sorry, can't see well. Okay, good. Stop. Come off. Let's keep rolling. Nice and slow.
If you start even higher, David, you
Keep
can
burning.
kind of come in and it'll act more axial for you over time.
Yeah, stop there. Let's do one more
you go.
Cine so we can see.
I think it's
Okay,
good.
and yeah, that's better. Just, I think we could start. It's going to go down a little bit further before it flowers. So keep going. Pace is on, right? Okay, perfect. Thank you.
Okay, slow.
Perfect. Maybe a little forward to it here. Okay. Sort of caught maybe on the edge of the valve, right? There you go. Perfect.
Okay, opening out.
Potentially helpful to pace any faster.
Yeah.
Pace a little faster.
No.
No, it's too high.
Gonna recapture.
Yeah, David, what I would do is start high and land almost at -1 as you're spanning out, then come forward and it'll bring the left side up. You don't want to be pulling.
And maybe pace fast.
Pace faster, yeah.
Wire in, please. Wire in, please. Okay, now pin the wire.
Pinned.
You got a little bridge there.
Yeah, back all the way up and disengage. You got to get far enough out you disengage, and then come back.
Okay.
Yeah.
So, Steve, you want to give Adam,
That's why you want to disengage.
Okay.
There you go.
Beautiful.
Sometimes if you can't easily get in, it could mean that you're on one of the leaflets, particularly on the recapture. Right? And so, and if you pull, and you tear a leaflet, then the patient gets sick. It all gets better when you put it in, but sometimes you open it up, pull back while it's still open, and just.
This is a great and challenging case from beginning to end, and I think this is a great instructional case. Okay, so I think we pace a little bit faster. What do you think, Mark?
Yeah.
And I would start a little higher so your final movement's in.
Okay. Mike, tell me when.
That's
like about
good.
right there?
That's good. Yeah, let it come out almost touch. And then when you come forward, David, the left side will come up and it'll become more axial.
I'm going to start.
Okay. Our pressure's still 94. Would you like us to pace faster or do you like that?
No, it's okay. The pulse pressure is
No, you're doing good.
That looks pretty fast.
The pulse pressure is on.
Let it come in some now, David. Get a little far out. Come in some.
Want that
Come in. There you go. Keep going.
Yeah.
David, I really like that catheter against the greater curve. So as you come in a little, push on that wire hard and push your catheter back.
Yeah. Keep the wire in, and that'll help you. Come forward. Yeah, keep going.
That's a great move.
Keep it in.
As you start to dive, push the wire hard.
Yeah. Keep going.
Better, David?
Keep deploying.
Okay, I'm going to go. Keep going.
You can see how it's already getting more axial with doing what. Push it in. There you go. Now let it come back to the center and let the left side dip down. You'll be good.
A little high there. You have to
Yeah, very high. Yeah, very high.
Recapturing.
Well, go ahead and
let's get
deploy
the
it and take a
pressure back.
picture.
Probably come off pacing.
Go to 2/3.
Bring your pacemaker down, please. Recover the pressure.
Watch the wire.
Watch that wire, please. I'm gonna disengage completely. Wire.
Got the wire. Pull back.
Okay, there you go.
Yeah.
Good.
There you go.
Let's
Good
recover the pressure. Give him a breather. You're not pacing, are you?
No, he's not.
Okay.
Slowly trying to get the blood pressure.
Got it. Mark, what do you think?
I think we just gotta I think we understand the positioning now, and I think there's a lip there going in, so we just have to, once we go deep, I just pull back a little, make sure we're neutral, and then everything else we do is just basically to get those 3 markers somewhere just at the base of the valve, and I think we'll be fine. But we can't be deep, because you could see that on this side, the left side looks much deeper, and this is the coplanar, which...
Bob, how's that ventricle holding up?
Stunned a little bit.
Okay, why don't we give it a little time for this to recover?
Yeah, we need it somewhere between that and the original.
Yeah,
That's right.
Somewhere between the middle of the valve and the bottom.
Yeah.
And Bob, is there any increased AI? Maybe the other reason.
We had a fair amount just getting the wire across, so yeah.
For a second. We're pressure's where we wanted to be, right?
No, I'm just thinking if a little
We've
trouble
got wide
coming
open
back.
AI is what we got,
what
really.
changed? There's
Yeah,
not an
so we made
infusion.
things.
There's not MR. Doesn't look like.
Coming up.
Yeah. Yeah,
No, it's wide open.
Yeah, I don't
AI.
think it's the wire doing it either.
The next
Is that
one
better
looks
now,
bad,
the AI?
Yeah. Let it be a little.
Did it get any better?
No.
No.
Okay, so we probably injured one of the leaflets.
Again, that's probably a
Okay.
leaflet that got torn on that recapture. So
So,
Right.
and what's our pacing right now?
It's backup pacing. This is him.
What is that?
Well, I think a lot of this may be AI. You may just want to pace it. If it just keep it going fast, that'll take care of it. It's trying to get over the leak.
Yeah. Why don't we just pace it 100 if that's okay? I can't see what the number is.
120.
Oh, we're at 120. Okay,
He's going on his own at 120
perfect,
without us pacing.
Okay, got it.
Should we try and get this in?
Yeah.
All right, let's go.
Wire right now is mid-ventricle.
Yep.
Yeah, let's move. You can step back a little bit with the probe, please. Thank you. There you go. Okay, perfect.
You got the wire. Okay, good. Right, you tell me.
Okay, so let's decide. Do we want to pace a little faster now?
Yeah, I might even think when you get partway out there, David, just pace 180 and put it out real quick and get it in there.
Yeah.
Okay, 180?
I mean, even,
No, wait till you flower. Wait till you start the flower. Yeah. Let me feel this for a second.
We're making him worse.
I just want to see.
Well, it's such a good illustration of how much interaction in valve-in-valve procedures there are that make it so different from a native implant.
Yeah.
And our ability to be precise sometimes is unpredictable like that.
Yeah.
There you go.
Okay, good.
We're a little overdriven over the capsule. The tip.
Yeah, that's why it took so long.
Yeah.
Great.
Tell me when.
All right, let's pace at 180.
Okay, 180.
Pushing it here.
20 and 40.
Yeah.
Good capture.
Okay. Sending that. Let's see if we're okay.
Okay, bring the pacemaker down.
Let's
recover the pressure. Bob, why don't you tell us what we got?
I think we're going to be fine.
I'm just going to do this a little bit.
Yeah. Let's get the parallax out of the bottom of this.
Looks like we got central leak, but really not much of anything else right now.
I think it's going to be great.
You got nothing really inside there. We might be a little bit deeper than the Lotus. We have no real pressure, so this may get worse as the pressure comes up.
So let's center the nose cone. 1 second.
Yeah, what do you think?
Did that help the pressure at all?
I think you should deploy.
Yeah, pressure's 94.
Deploy under fast pacing right now. I wouldn't bother with anything else.
Yeah.
You can't assess.
Yeah.
Okay.
Okay.
All right, let's go. Why don't we pace? So we're going to deploy now?
So wait till it goes to 180.
Pressure up a little bit more.
Okay.
Yeah, sure. We're stable now. Yeah, and you're keeping a little forward motion. A little forward button.
Yeah.
Raise the pressure.
No, do not do that. It should be centered in those.
Yeah.
Well, there's no rush now. The valve's functioning. If you're worried about your coronaries, you can take a picture and take a look at it right now, but I would say there's no rush.
Yeah.
You can bring your wire all the way back in the capsule. You can deploy if you want to, but there's no rush.
Yeah, that's what we're going to do.
Okay, he's rapidly pacing. So
Okay, Bob, come back. Bob, come back.
Yep.
Bert,
I'm going to go slow.
go.
And then a little forward on your side, David.
Okay, go ahead.
Going.
A little forward.
Okay.
A little forward.
Okay.
A little forward. A little forward. You go a little faster now. A little forward. A little forward. Beautiful. Beautiful, guys. Beautiful. Perfect.
Yeah,
That's
perfect.
exactly what we're going to do. Okay.
Okay, and it's on. All right, let's put the wire in and let's bring this up and over.
Yeah.
Advance
Pacer.
Just wire into the.
Advance the wire
Advance it. And then just pull the nose cone back.
and pull the nose cone back.
Slowly. And
Pacer
now
down,
push
guys.
wire out.
Yes,
Push
pacer
wire
down.
to the apex, please.
Yeah.
Perfect. And then pull it out. Okay, good.
No, that's
That's great.
Okay, things are going great.
That is easy.
All right. Really? Did you have to? I know everybody said they loved your sensitivity.
Let's get a.
Let me just recapture this. Hold this.
Come straight AP, please.
This thing's going to need to.
Some
How big a balloon? What kind of true are we going to use on this?
I thought we'd just. Oh, I didn't. That was a different case.
Okay.
And we're going to walk this out and we'll take some.
Leave that wire in
Make
there.
sure that wire's.
Big, open up the field. Yeah, there you go. Go ahead. Come on back. 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 Leave that wire in there, please. Wire, good. And I have wire. All right. Okay. And we have, here, give me a syringe, please, quickly. We got to fill this up. Okay, run it, go. In. Okay. Oh, damn it.
Everything okay, Joe?
No. Yeah.
Oh, the balloon broke or something?
Yeah.
That sounds terrible.
I got a thing here.
Oh, the
Seal broke.
All right, so let's just exchange. Can we have another dry seal, please, quickly?
18 French dry seal.
The seal and the dry seal. Yeah, Bob, you want to go through the echo, please?
Yeah, so we're definitely underdeployed on the inflow side with the Evolute.
Next name's easier for me.
You can see we got a couple of
got the thing there?
millimeters gap there.
Okay, we got a couple. So why don't you go on top and then walk it
We
out?
do not have any real paravalvular leak,
Cap this
though.
up. I'm going to go on top.
No, let's do the wire. Please,
Wire, floor.
Thank you, guys.
He's going this 120 is him, right?
Yeah. Okay. New dry seal, please. Thank you.
Oh, and Bob, I wouldn't expect the Evolute to come against the wall of the Lotus. Remember, the Lotus is a cylinder and the Evolute's an hourglass.
Beautiful.
Yeah, it does look like it's actually coned down, though.
Yeah.
So what says true balloon?
Well, that's a great. So we could use keep on echo, Bob. Just go through the echo while you're showing the echo. So given the sizes that you saw and everything, what Yak? What do you say, or Adam, about the size of the balloon?
David, remind me of what Evolute you used on this and what the Lotus size was. 26
25 Lotus, 26 Evolute.
Yeah, I think that when you look at the frame of the Evolute compared to the Lotus, it looks like you have a little room to expand. But really what you want to see is where the coaptation of the valve is on echo. I'd love to know what the gradient is here too. But if I had to post-dilate this, I'd probably use a 22 balloon. I think that would be more than
Size of the valve.
22 true.
That'll round it out. And if it doesn't get better at 22, it's just not going to get better.
Yeah, I think you would think about a 22 Evolute or a 22 true balloon. But I'd love to see what the gradient is right here.
Someone put their hands on a 22 true, please. Yeah. 22 true.
I need you to hold back tension on that, please. Can you come all the way down to the groin for me?
Yes.
I need to see this. Push away from me. Push away from me. Okay. I want to see that. Good. That's what I wanted.
There you go.
Go. Let's see.
Okay, before you pull the introduce, let's make sure we're good with the wire and the ventricle.
Yeah. Let me see the wire in the ventricle. Higher, please.
Just move the table.
That's great.
And then when you do that,
I'm going to have
I think it's already filmed.
Yeah, I'm going to have you take over. I got to change.
Okay, well, you look great.
Can I have another gown and gloves, please?
If you want to just walk that out, feed wire at the same time, watch the wire. Flora, please, stop. Wait 1 second, stop. Flora, please.
Yeah, thanks.
Flora? Oh. Okay, just get the wire there. Perfect. We get a little bit more, and you're out. Perfect. Okay.
So wait.
And this is good. Take that. All right, we're going to give you some gradients. Bob, you want to chat with the team at the hotel and let them know what you're seeing?
So I'm trying to get a good gradient here. We're not getting a real clean signal right now, but it's not looking like if we have any significant stenosis right now. I suspect that we may have a better window. But at least at baseline right here, which is a limited one, it's not really initiating when I'd expect it to. We only have a gradient of 12. That's not looking terrible.
A mean
What
gradient
I'm
of 12.
not happy with is the fact that we had a tough window to begin with, and now we're having a real hard time getting that to clean up.
All right, so maybe what we can do, if everybody's in agreement, we post-dill it, and then maybe even take an injection, and with the pick, we have something from the wrist, and then we'll go from there. Okay.
Yeah. Why don't you take 2, I'll take 1.
Absolutely. Sure.
No. So, Zain?
Yes.
What's the
We got a
challenge of a
syringe with some
re-op on this
contrast.
explanting a lotus? I mean, we're talking about doing valve and valve. The patient was turned down for surgery and whatnot. What challenges with looking at that braid frame? What do you face in the operating room when you're trying to explant these TAVR valves?
Not that I've done one, but the epithelialization and how close it is to that aortic wall is going to be a pain in the ass. So,
who's prepping the true?
I think Joe, Bob, Riley, you guys also may have done a lot of re-op TAVRs. What I found is that if the sinuses are large like this, it makes it kind of easier, so you don't have to do a root. But the good thing is that if this doesn't touch the aortas and very small annuli, then I think it helps you in that regard. And I think we're lucky here because of the annular size and the sinus size. But the pain in the ass would be really the root, and if this is epithelialized or not.
Fair enough.
Joe, what are your thoughts?
Joanne?
Okay. Do you guys don't use an inflator as well, or just a straight up? Just hand. Okay. Good. Okay. You want to grab it?
Yeah, I got it.
Just give me a little tension.
Yeah.
Are you guys still with us? You guys are so quiet.
There's that.
I think the bathroom's open, so they're all gone to the bathroom.
Sometimes it's a little hard for us to hear you, David, but Mike, I'm curious. I bet the audience is thinking, we don't see a high gradient. We're not seeing regurgitation. This is an older patient. What are you concerned about with leaving this, and why move forward with the 22 true for a post-still?
Yeah, so I think there's a role for actual hemodynamic gradients. So they're having difficult time seeing with echocardiography to begin with. So I want to confirm those hemodynamics. You want to make sure there's no infolding of the valve. You can often assess that by swinging the gantry around and looking in 2 different dimensions, but also in a short axis. And you just want to make sure that it is as fully expanded as you can get it, because I think we've learned that underexpanded frame is not necessarily a good thing. I think that may be less important with a evolute, but it's still probably important for all valves.
Look at the inflow there, Michael. You can see it doesn't come out to the lotus. It's not fully expanded, and underexpanded valves are bad, and a 12 hemodynamic gradient is going to be an 18
you're not pacing
on echo.
And we learned from the accurate experience that good gradients and lack of PVL is not the only thing that tells you something about long-term outcomes.
Yeah, look how it came
out. You can see that inflow go out.
Yeah. Wow. Yeah. To Mike's point, that really expanded nicely.
We had a Vmax of 3 meters per second, so that was definitely not a good sign to leave that alone.
Yeah, we just post-dilled, and it looks like it really did move.
Carefully.
Mike, I agree with going to REO. It's always a good look at
I'm not doing anything. I'm just holding negative here, so I don't want to get caught. Okay.
Wire?
You got there?
Thank you, sir.
Push the wire.
Wire.
I got you.
Make sure that doesn't get
You
caught
got
on
it.
it. Okay.
Pigtail next.
Okay. Wait 1 second.
Sorry about that.
Good job.
I think I lost. Okay, could we come out here?
Pigtail, please. So, Bob, jump in there. Tell us what we got.
Yeah, that really made it different.
Totally.
That was good.
Okay.
It almost sounded like Mark hurt himself on that balloon.
Hey, yeah, I think he's had a hernia.
Is there Is there a general surgeon in the audience?
So, I mean, I think one of the important things about this
with that big
case
syringe, you got up to 2 atmospheres.
is that when we're talking to patients, we need to be thinking about more than just putting a valve in, but what we're going to do the second time. And that's why I think it's very important for patients when they're younger to think about a surgery the first round, because the frame is a little less pronounced. You can potentially frack it. There's a lot of potential good things you can do with if your first valve is surgical. That's what I think, but others may disagree. I know there are people who feel strongly the other way. But what do other people on the panel think is, if you're a 72-year-old and healthy, should your valve be a TAVR or should it be a SAVR?
I think you can absolutely make the point for surgery, but I find that difficult in this day and age. Right. Patients are asking for different things.
So just the only thing, just get that true ready again, and just hook up an indiflator, like a 3-way indiflator, whoever was prepping the true, in case we need. I just saw a high gradient to go by. I just want to make sure we don't need to hit it again. Yeah, so I just need, I want the syringe and an indiflator.
Yeah, I don't know
what is he getting there?
Let's get a pressure here.
Yeah,
let's get a real gradient.
I need a second.
Ooh. Yeah, it's a funny looking.
I need a second pressure transducer.
So we got 2.8 and mean of 17 right now.
Question. Well, I mean, are you on any inotropes? Are you whipping the heart at all? I mean, it was down a little bit. If
what are we doing up there, Vince? Vince, they're asking about inotropes, and are we doing
minimal norepi right now?
Yeah, it's low dose norepi.
I mean, the real question is, if you increased your flow.
Infusion?
Pardon me? I mean, sometimes when these people are down, they get put on things up to whip them up, and then you got to.
Bob, do we have an infusion there?
Let's take a look.
Question for the panel. For this valve-in-valve, if you think that the first valve fails with HALT, are you going to put all these patients on warfarin?
I mean,
I don't know. I think that's a great question, Jim. I mean, it's interesting because we had the 40 CT sub-study, but Jonathan was part of, for the low-risk trials, and there were people that had HALT at 30 days, it went away on its own, and some that had no HALT at 30 days and came on. I will not even pretend I've figured out HALT yet.
So forget HALT, just valve-in-valve.
Valve-in-valve, I put them on for at least 3 months.
Up front, it's not much.
It's all true. Okay, so
I think it's a good question, though, as it relates to treating the failed surgical valve, or in this case, the Lotus, as far as actually lacerating the pannus or creating more space prior to the deployment, not necessarily as it relates to anticoagulation. I think there's some early learnings with some novel techniques to try to improve the landing zone.
I think it's as good as we're going to get there. Yeah. I'm glad we went higher, so we benefit from the superannular issue. The only question you could ask, I usually use a pressure gauge also with the True, because the rated burst is 6. So I usually give it, and then I just bring it up to 6 to make sure. But this looks pretty reasonable.
Yeah, it does.
But that's one thing we can do.
Don't poke a skunk,
right
Mark.
now. What?
Don't poke a skunk.
I know,
you look pretty good right now.
Yeah, believe me, I know that skunk well, and I tried to avoid him.
Let's get a real gradient.
So it doesn't look like there's a lot more.
Yeah.
Say that again, Bob.
Last are 10 and 12 for our gradients.
Oh, 10. That's not bad.
Erms, are you going to give us an invasive hemodynamic gradient?
Yeah.
Yes.
Do that,
that's what I'm want to see.
We'll see what that looks like.
Move people up from later today.
Let's see if it went down.
You can do. We just need another pressure.
That's we're getting another pressure transducer.
Okay, perfect. Mike, to your point, it looks like we got a good inflation on the first one. We're not obviously moving this valve. I just don't know how much better we can do.
You're not going to get any better,
like where
Mark.
we landed.
You've done what you
Pardon
can
me?
do with this. You're not going to get any better. I mean, this is what you're going to get. You can't explain the Lotus isn't go out. You've done a balloon that's as big as the valve.
I wouldn't go to a bigger balloon. The question was whether or not we got the most out of that.
It's not going to make
and
any
I think we
difference.
did. I agree.
This is a great result for this patient. It's a low gradient. He's going to do great. I wouldn't criticize this at all.
I think that's very fair.
We're going to get an invasive gradient here. Bob, your last gradient was what?
Mean of 10 to 12.
And
10 to 12,
what does that translate into?
Peak velocity or what's the peak?
You got an EOA?
EOA was 2.1, I think, or 2.2, or something like that. What was your AVA?
So calculated valve area 2.8, 2.3 by velocity.
This is going to be a winner.
Yeah. I'm beginning to like it more and more.
So Bob, do a DVI for us real quick and tell me where you are.
Now let's see what we had. We had VTI of 40. And
okay, keep that closed.
Sorry, like this?
Yeah, keep that closed.
That's actually not bad at all because the LVOT VTI is 28 and the aortic valve VTI is 40. I have to get my calculator for that one, but that's
great.
Nowhere near 0.25. That's for damn sure.
Okay.
It's over 50.
That's pretty good.
Yeah, acceleration time looks short.
I mean, anatomically, it's a little dissatisfying because we got that gap at the base of the inflow.
It's so much better after your balloon about. I mean, I think the balloon opened up very nicely.
It's folded in. Yeah, I agree. I think we'd be marginal benefit with whatever risk.
I like the idea about not poking the skunk.
Yeah.
That's all panis. It's not going to go anywhere.
Fair enough. Okay.
Okay, we're just
it wasn't hard to convince us.
Yeah, right. Give us one more second to try and get you an invasive.
Yeah.
And we really have no leak whatsoever. There's no real regurgitation here at this point.
Tell me when you have that. I am. Brett, flush. Lots of flush here. Keep going. Keep flushing. Want to get all the contrast and everything out of there. Okay, give me a good flush. Okay, wait. Patient. Okay, now we're going to zero here, stop. Let's zero on both. Can we get simultaneous? Zero on both?
I like the attention to detail on this because it's really important. How do you all feel about Langston catheter versus two
like
catheters?
That. I like the Langston. Learned on the Langston, but okay, now we're going to give.
Yeah, but this is nice. You've got one up in the ascending aorta.
Look at that.
I think we're good.
Yeah, good.
No, that's all right. Awesome, great. Thank you, Rick, for the help. That was great.
If you put your ventricle on the 40 scale, we'll see the LVEDP, but it looks pretty low.
Yeah. You put us on the 40 scale for the LV, please. Just want to see what the LVEDP is. The diastolic pressure, if you can see it, is 55. So we're right now 118 over 55.
So your LVEDP is pretty low there, so you know the patient's going to get better.
All right.
Yeah, switch the transducers just for a second.
To switch them?
Yeah.
You want me to switch these two around?
Just for kicks.
Take that, please.
That's your double density right there. So inflow
I love doing that, switching the transducers to make sure that you get the same result. Yep, that's very important.
Here.
Good, take that, Jimmy.
It's only when you live in Indiana you're worried about these kind of things.
The other way, and that's the Lotus.
Okay.
In New York, we don't have to switch.
Yeah, we trust but verify.
Yeah, there's no paragraph.
Okay, flush, please. Flush. Flush here. Okay, stop. Now to patient, go. Okay, let's 0 on both. 0 on both. Okay. Go to 200 scale again, please. 200 on both, please. We're going to 0 again. Tell me when. Okay.
There you go. So the real gradient is probably about half of wherever we were before, right?
More importantly, you really phase shifted. You look like you're tasting from the groin. It looks like
It looks like, we'd have to, I don't see, at least the peak to peak there's no difference.
I think
It's
we're
very
good.
small.
Yeah.
It's very small.
Okay. All right. David?
Wow.
Yeah.
Wow. That was very challenging. It, I think, underscores, I think it was Megan, said that valve can be challenging. It's not always, putting something inside a magnet and walking away. And
can I tell you what I learned?
Yeah, please.
Yeah, I learned something then. So I always knew that, and Mike, you were basically suggesting this, that the Lotus valve does not respect the anatomy. However it's put in is the way it deploys. And watching this and just some of the orientations I see on the echo, I think doing shallow deployments is important because because the core valve or S3, whatever you put in here, is going to follow the natural course of the Lotus. It's nothing's going to change. So I think that's something that I noticed on this case, which is I think interesting.
How many people have? So, did you say that you've done a valve in Lotus, or you've done a couple of valve in Lotus, or what?
Yes.
I think he said he's done 2.
I have done, I think 2 or maybe 3 valves in Lotus.
Yeah.
Yeah.
And what was your experience?
Well, the ones that are challenging are when the Lotus valve is over the coronaries and you have no surgical option. That's by far the most difficult. And so that requires either trying to modify the leaflet, which is really hard in a Lotus, or it is trying to protect the coronary arteries.
Hey, Bob.
So you're only lucky if you have coronaries that have been bypassed on Lotus valve and valve, because most of the time you don't have this kind of room in the aorta and the distance to the coronary arteries.
And modifying the leaflet usually doesn't help because the leaflet just comes to the top of the Lotus valve, which is, despite the fact that David can shove his way through, it's a pretty solid thing. It's like a wall. So, what I haven't done is I haven't expanded any surgery yet, so I'm interested to see what that's first.
Is there an infusion? Okay. So can you do me one favor? Go to the, okay. So I got, somebody got a 10th and the rest of and all the, and okay. And all the rest of us are zeros. That's amazing. Okay. That's one thing. Second thing is, could you, we use a lot of Manta for closure. It is a great closure device. I'll show the Manta closure when I get back to the ballroom. But thank you very much, and thanks for all your help, guys. It's a very challenging case. Mark, Herms, Zain, thank you all very much. And Per, thank you for giving us a challenging case. All right. Talk.
Yeah, beautiful result.
Great.